Hello, this is a Wheezing semiology presented by the SchrDbb. We reference a practical guide to issue taking and clinical examination by Anwar Qais Saadoon. Hello, so now we're going to visualize wheezing. So what is wheezing? So wheezing is a continuous musical sound heard mainly during expiration. Continuous musical sound heard mainly during expiration. Example of a wheezing sound just here. So it is produced during expiration. So it is as a result of a partial obstruction of the intrathoracic airway. So although wheezing is usually heard during expiration, it can be both heard also during inspiration expiration. So at times it may have times where it is heard both during inspiration expiration. Like example, is mostly during a labored expiration because obstruction is due to a lower respiratory tract obstruction. When you have obstructive pulmonary symptoms, you have lower respiratory tract constriction that prevent air from moving out. Though air is not prevented from entering in, but air is prevented from going out. Are you getting? So since air is prevented from going out, so you have more labored expiration, but air is not prevented from going in when you have a constriction of the lower respiratory tract. Instead, if you have a constriction of the upper respiratory tract, you are instead going to have a stridor, and a stridor is a loud high-pitched sound, as you're going to see later. High-pitched sound which is produced when you have constriction instead of the upper airway. Wheezing is produced when you have constriction of intrathoracic airway, that is the lower airway. Are you getting? I hope that you are. There's a difference between the upper airway and the lower respiratory tract. Are you getting? The upper respiratory tract is till the bronchi. Are you getting? So we have upper respiratory tract. Upper respiratory tract is till the bronchi, while the lower respiratory tract is from the bronchi downward to the bronchiole and the alveoli. Are you getting? So that is the upper and the lower respiratory tract. The word wheezing is frequently imprecisely used by patients, by the patient's parent. So you need to emphasize more on how the sound is for you to know very well to clarify what they are talking about. So viral bronchiolitis and asthma are most commonly caused. Viral bronchiolitis and asthma are the most common cause of wheezing, and usually you consider viral bronchiolitis when the child is less than 1 to 2 years, and you consider asthma when the child is greater than 1 to 2 years. When the child is instead greater than that, you think of asthma. So now, what are the short case scenario in children with wheezing? If you have a boy of 7 years with a history of atopic dermatitis and is referred to your hospital's outpatient department because of a long history of recurrent wheezes. One, he has recurrent wheezes, he has breathing difficulty, and he has cough. He wake coughing and wheezing early in the morning, 2 to 3 times a week. The symptoms often occur with exercise and sometimes interfere with sleep. Bronchial dilators alleviate the symptoms. According to his mother, he had tended to be wheezy since 7 months. His 4-year-old brother has eczema. So you have eczema in his 4-year-old brother. He has atopic dermatitis. All that plus asthma produces atopy. So this makes the diagnosis to be asthma. Why? Because he has a issue of recurrent wheezes and breathing difficulty with cough. The symptoms often occur with exercise and in the night and impulse with bronchodilators. There is usually a family issue of asthma, and in this case there's a family issue of eczema, which is associated with asthma in a syndrome called atopy. There is a strong association between asthma and atopy diseases such as eczema, rhinoconjunctivitis, and food allergy. Exactly. So that was the first case scenario. The second short case is a 3-month-old infant present with wheezing associated with dyspnea rhino. So he has wheezing, he has dyspnea rhinoia, he has sniffle, cough, fast breathing, irritability, poor feeding, occasional vomiting. So here we have wheezing in a child of 3 months. I've told you this child here was 7 years, that's what you think of asthma, but this child is less than 1 year, that's what you think of bronchiolitis. And why? So the common age is 1 to 9 months. It's uncommon after 1 year. The condition deteriorates at night, and it gets worse over the course of 3 to it deteriorates much more at night, like just like asthma, and get worse over the course of 3 to 6 days. Small and premature infant can develop a recurrent asthma, so apnea, with serious complications. So you need to bring your child to hospital. Though it is when the main cause of this is viral, you need to bring the child to the hospital for a conservative management. So the next one is a 6-year-old onward with 6-day history of wheezing. We have breathing difficulty, you have cough, you have chest pain, you have fever. The last day before admission, the condition get worse. The fever increase and become associated. So if you have fever, you need to think of an infection. Are you getting? But now in this case, it may be a pneumonia, or it may be an upper respiratory tract infection. Are you getting? For bronchiolitis, usually, as you have seen here, you have 3-month wheezes, dyspnea, cough without fever. They have not spoken about any fever here. Are you getting? You have just mostly difficulty in breathing. But if you have fever, you should think of an infection. It can be an upper or lower respiratory tract infection. And the best way to distinguish between an upper and lower respiratory tract infection, you may have still wheezes inside inside pneumonia, but the main thing that distinguishes pneumonia is that we have a consolidation syndrome. And what is a consolidation syndrome? On consolidation syndrome, on inspection, you're going to have one side chest movement is going to be unequal, chest expansion is going to be reduced on the affected side. So you are going to have an increased tactile phonitus on that side which is affected. 3, you have the percussion is dull. 4, you're going to have bronchial breath sound. And 5, you may have crepitations. Those are the 5 consolidation syndrome. Are you getting? So when you have those consolidation syndrome, you can now say pneumonia plus a wheezing plus a breathing difficulty plus that you can think of now pneumonia. So here you have a child is unwell, you have weak cough, fast breathing, chills. So you have pleuritic chest pains may be present. If you have a pleuritic chest pain, you can think of a pleural effusion in that side where there is a pneumonia. So, and the condition usually often deteriorate over days. That's pneumonia. Now, the next one, you have a 2-year-old healthy child with a 3-day history of wheezing, and so you have things you need to know that what wheezings can be divided into 2 parts. You can have generalized wheezing, which is present in bronchiolitis and in case of asthma, or you have only localized wheezing in case of pneumonia and foreign body aspiration. If you have a sudden onset of wheezing on one side, or on which is located on one side, which does not respond to medication, located and on following sudden choking, you can think of a foreign body aspiration. Are you getting? And it's much more common in toddlers. You have a history of a sudden choking with small object inhalation may be present in a healthy child. The symptoms do not respond to medication. So now, the history taking of a patient that has wheezing. So we first have with the identification. You have the chief complaint, which is wheezing. Wheezing, actually, you will not say wheezing on your chief complaint. You say the word of the patient. The patient is going to say that my child has noisy breathing, or my child has an abnormal breathing sound. So on the issue of present complaint, we speak about the onset. Is it sudden due to the foreign body aspiration, or gradual miscarriage and infection? The duration. What is the duration of the wheezing? Is the wheezing a new, so the duration is actually acute or chronic? Is it a new or it's old since the timing? Is it at night? Is it the morning and all that? If it's in the morning, wheezing, coughing may suggest GERD, gastroesophageal reflux disease, and sensitivity to common to bedroom allergen. So we have the next one. We have progression of severity of attack. Compare the previous episode. Does it interfere with the child activity? That's wheezing. And you need to know that what interfering with the child activity can also make you think of if it's asthma, it can tell you the grade of the asthma. Is it clear? Because we grade asthma based on 1, we have the daytime difficulty in breathing. 2, we have the night cough, and 3, we have the activity that the patient can do. Those are, and also we have the peak expiratory flow. So those are the 4 characteristics which are used to distinguish between the different type of asthma. That is, 1, we have intermittent asthma, and 2, we have persistent asthma, which is divided into 3: mild, moderate, and severe asthma. So we have so was the episode of wheezing preceded by choking or gagging? So are there aggravating or relieving factors such as exercise, emotions, specific season, cold air, humidity, respiratory infection, feeding, and all that? So so we have feeding. So if you have any feeding difficulty, you can think of a GER. This is associated with feeding. You think of GER or tracheoesophageal fistula, as I've told you. Agitation or crying. If it's associated with agitation or crying, so you think of tracheomalacia, bronchomalacia, or fixed intra or extraluminal obstruction. So what are the triggering factors? Maybe tobacco, it may be strong odor, it may be fumes, it may be chemical, it may be dust, it may be animal handling, it may be infections, meals, exercise, change in season, or change in temperature or humidity. So what are associated symptoms? Associated symptoms are trying to roll in or roll out the diagnosis. So you can have cough, it can be sputum, it can be hemoptysis, fever, chest pain, sinuses, running nose, sore throat, inability to communicate. So now the next thing, now we have the past issue. So in your past issue, we have the birth issue for a patient that has prematurity. A patient that has been premature and then he persistently have wheezes. You can think of bronchopulmonary dysplasia in a child who has two. That's why the birth issue is very important with a wheezing patient. The next one is premature rupture of the membrane during birth. Now, how does premature rupture of the membrane during birth help? It can also imply prematurity. Are you getting? So we have mechanical ventilation or prolonged supplemental oxygen to the child, because prolonged oxygen also in a child who has neonatal asphyxia or prematurity can predispose you to have bronchopulmonary dysplasia. Are you getting? So if you give excess oxygen to a child, that's why excess oxygen is not nice, because excess oxygen can result to pulmonary trauma to the lungs, and it can cause a pneumothorax. It can cause bronchopulmonary dysplasia, and it can cause retinitis of the retinopathy of the newborn, optic nerve retinopathy. So those are the 3 main things that the excess prolonged oxygen in a premature can give. So now, if you have past medical and surgical issue, you have previous episode of choking. If you have previous episode of choking, you can think of impaired swallowing. So we have recurrent chest infection. If you have recurrent chest infection, you can think of any disorder can give this child an immunodeficiency, or it can also be cystic fibrosis that can prone you to recurrent choking, or it can be a Cartagena syndrome where you have impaired cilia. Are you getting? And you need to know that what Cartagena syndrome has a triad of 3 things. The first thing is a dextrocardia in Cartagena syndrome. The second thing in Cartagena syndrome is sinusitis, and the third thing is bronchiectasis or bronchiectasia. And that bronchiectasia is because the cilia is impaired. So you have the next one now. We have recurrent chest infection, we have asthma, we have congenital heart disease, you have congestive heart failure, you have cystic fibrosis, immune deficiency, allergic rhinitis, food allergy. You should look for all this. So if there is recurrent attack of wheezing, ask about the age of onset of the first attack. Trigger, the frequency, the severity can make you think of an asthma. The next thing is medication issue. Is a bronchodilator used to reduce this? Are they using home nebulizer? Is there a recent use of a beta blocker? Because beta blocker can precipitate bronchoconstriction and precipitate wheezing. So beta blockers, aspirins, non-steroidal anti-inflammatory drug, all do bronchoconstriction. So now the next thing now is development. So we have developmental issue. Under developmental issue, we have the developmental delay, we have growth retardation. Immunization issue, we have BCG, we have diphtheria, pertussis, tetanus, and all that can result to disease. We have feeding. Is there poor feeding? Is there feeding difficulty? We have family issue, asthma, wheezing, allergies, and all that. Social issues, smoking, traveling, hospital, and overcrowded house. And you will look for the review of system. So from there, we now continue to the nota bene points of wheezes. The presence of a wheeze at birth or early infancy is you should think of a congenital structural abnormality. If you have a wheeze from the child who is born, are you getting? You have a wheeze in a child at birth or early infancy, you think of a congenital abnormality. Now, recurrent episode of wheezing, cough, dyspnea, chest tightness, which may suggest asthma. Now, in previous well infant, a new onset of wheezing. In the previous well infant, a new onset of wheezing in combination with symptom of upper respiratory tract infection. If you have a symptom of upper respiratory tract infection, then you have a wheeze. You can think of a bronchiolitis, respiratory bronchiolitis. Recurrent wheezes. So if I have recurrent wheezes may imply a gastroesophageal reflux disease. Recurrent wheezes, particularly if exacerbated by feeding. Are you getting? It triggers upper and if triggered by upper respiratory tract infection. If you have a recurrent wheezes, you can think of a gastroesophageal reflux disease. So essentially when the wheezes are treated with feeding. Now the next one is if it is triggered by an upper respiratory tract infection, you can think of a reactive airway disease. Are you getting? So the next one now is the persistent wheezing should lead to consideration of mechanical obstruction. The mechanical obstruction, which may have a number of causes. So if you have a persistent wheezing, that you use medication like bronchodilators, it does not relieve the wheezing. So you can think of a mechanical obstruction, which may be due to one, you have an airway foreign body. Number two, that's an aspiration of a foreign body. Number two, you have external airway compression. Number three, you have congenital airway narrowing. You can think of that those mechanical obstruction. Now, if you have recurrent wheezing, especially along with recurrent chronic diarrhea, so wheezing plus recurrent chronic diarrhea since the early infancy, that difficult to control should raise attention to cystic fibrosis. Additionally, probabilities, but this cystic fibrosis is not usually present in our country, that's in our context. What we have more here is sickle cell anemia. So we have additional probability are primary ciliary dyskinesia. If you have primary ciliary dyskinesia, you can think of with recurrent wheezing and chronic diarrhea. Primary ciliary dyskinesia in cases of Cartagena syndrome. We have a recurrent aspiration. We have anatomic anomalies and we have immune deficiency. Can make you think of that. Wheezing associated with failure to thrive in spite of good appetite and suffering. So and steatotic stools, recurrent infection may suggest cystic fibrosis. From here, you are finished with wheezing. I will say thanks for your kind attention.